The National Health Laboratory Services is briefing the media in Parliament on their strategies and plans to deal with COVID-19 test results as well as backlogs. So we take you live now to that briefing in Parliament.
Thank you very much, Honourable Chair and Honourable members of the Portfolio Committee. I'm just going to share the presentation. Can you see the presentation, Chair?
Yes, we can.
Okay, so thank you very much, Chair. As you indicated, you don't want me to go through any of the details. Everyone is aware of the National Health Laboratory Service, and maybe just to start with the. Oops. Just go back. Sorry, Chair. I've just skipped a file. Yeah, I can't see the. Just put the first one. So, Chair, just to say that. In the NHLS has been increasing the number of tests on a month-to-month basis, and you can see that there's been quite a massive increase of the number of tests that were performed in May. In April, we did about 95,000 tests. In May, that was more than doubled to 232,000. And in the first week of June alone, we did 105,000 tests. So you can see that we've been increasing the number of tests that we're doing. And this slide gives the breakdown of the number of tests per province. I'm not going to go through each one, but you can see that the highest number of tests that were done is in Gauteng, and followed by the Western Cape and then the Eastern Cape. But the positivity rates between the provinces differ quite a bit, because the Western Cape is the highest with regard to the positivity rate, but you're well aware of these issues. This just gives us an example of the number of tests that we're doing on a daily basis. And again, this is just the number of tests per week. And you can see that almost every week, since we started testing around the 8th of March, that we have been doubling the number of tests that is done within the NHLS. The last number is basically the tests that we did yesterday for this week. Chair, you had wanted to know about our capacity for testing. Just to remind the members of the committee, so basically there's two processes that has to be undertaken when we collect the specimen. One's the extraction of the RNA from the virus, and then once that is done, we then do what's called an amplification of that RNA, which we convert into a DNA, and then interpret the results. Now, the reason as to why I've elaborated on that is that we've got two types of machine. The one is a separate a machine where we have separate extraction and separate the amplification. And these are what we call our open platform machines. So it's a long, tedious process, because we take the virus out, we then take that sample, and then we put it into the PCR machine in order to get the test done with regard to amplification. So the throughput for these machines is not that high, both because the extraction of the virus takes some time, and you can't do that many within an hour. The second types of machine are what we call our integrated automated machines, where the machine itself does both the extraction as well as the amplification. And these are high throughput machines which is the Roche Cobus and the Gene Expert. The Abbott M2000 is, whilst it is an integrated machine, the throughput is not as high as the other two machines. So these are the machines that we've got. I'll go into details about the machines that we're going to get. The reason as to why I was giving that explanation is to show you that when we with our separate extraction and PCR platforms, those machines can do about 5,000 tests in 24 hours. With our high throughput machines, this is the machines that we use for the viral load, which is the Roche Cobus, and then the Gene Expert we use for our TB. We've looked at the spare capacity with those machines, and together we've got 15,000 in 24 hours. So that's where the number of 36,000 comes from. It's a combination of all of those machines. And that number represents the capacity that we have, which means it's the throughput in the machine. So the machines are capable of doing those number of tests in 24 hours. This just gives you an idea of the distribution of those machines. Northern Cape isn't here, but that's something that we'll be looking at going forward. So this just roughly gives you the idea. Then these are the number of extraction machines that we've got in the different provinces. And the reason as to why I'm elaborating on this is to give the committee an idea that with regard to our open platforms, we have got on hand, we have got a lot of kits, that's over 500,000. That changes as we use up the machines, but we still got a good supply of that, and we know that we will also be able to get those kits from our manufacturers. But where the problem lies is in this area here, where on a weekly basis we are getting 10,000 kits from Gene Expert and 10,000 from Roche. Roche has slightly improved it now to 19,000, but it's not guaranteed. Gene Expert has been saying that they are going to be increasing the amount. That hasn't happened as yet. And this is where our limiting factor comes in, is because we were expecting that 15,000 per day, as I showed you in the previous slide, but what we're getting is that number per week. Okay, and so that's where our capacity problems have come in. This is the other capacity problem, is that whilst we've got a number of PCR kits, as I've shown you, it's the issue is the extraction, because internationally they're short of extraction kits, and so the suppliers, and you can't get other suppliers, you have to go to these suppliers. The suppliers ran short of kits, and they've indicated to us they're not able to get any more than what they're getting. Over the last 3 weeks, we've been improving on the number of kits that we've been getting from Nimbus, and that has impacted, as you see, on the numbers that we are putting out, because at least we are able to do a lot more because of that. So, Chair, this is where we are with regard to the backlogs. We had a very difficult time during May. It's been a very difficult period because the number of samples we were getting on a daily basis was increasing rapidly, but it was the same time when the suppliers started running out of supplies, and so that's where we ended up with a huge backlog. But as you can see, we've been processing those backlogs down, and as we stand now, it's about 63,000, but we'll be improving on that quite dramatically. So this gives a breakdown then per province, and what we've been doing is systematically working through the different provinces. We have prioritized the Western Cape because of its high positivity rate, and we know that what happens in the Western Cape now is going to impact on the other provinces. So as a result, we have been giving them extra kits in order to reduce the backlog. That's the high throughput kits, but we still have been making sure that we cover all the other provinces. So Western Cape, we've reduced the backlog from about 18,000 and 15,000 the end of May, and you can see we've radically reduced the backlog to where it stands today. It's the same in the other provinces. We still have a challenge in the Gauteng province, and we're busy trying to sort out the backlog. The other priority province for us is the Eastern Cape, where we've brought in a whole lot of new equipment in order to sort out the challenge in the Eastern Cape province. So what we've done is we've got testing priorities where we prioritize testing for those with the medical need and for clinical diagnosis, then testing for high-risk individuals, testing of critical frontline workers. The surveillance hasn't come in yet. I'll talk a little bit about it towards the end, and then screening and targeted hotspots. So Chair, just to say that with those categories, we've color-coded it, and we've improved on the workflow. So we've been trying to make sure that we prioritize the in-hospital patients. This is an example from Western Cape. We've looked at the turnaround times for the hospitals in the Western Cape for the inpatients, and we know that that the results get given within 24 hours. So this is the average. In some instances, it's a lot less, and you can see that our turnaround time for the in-hospital patients. So the point that I want to make here is that our backlog is mainly in community screening. The hospital patients who are at risk and who need a clinical diagnosis, we make sure that they prioritize so the backlog does not impact on them. Okay, so we make sure of that, and that's why we've tried. We're categorizing the patients now, so we can assist in getting that prioritized. This just gives you an example of well, we looked at the number of platforms that we had. So one of the strategies that we used is we started off with standardization, and then the standardization was a problem because if one company couldn't supply us with the kits, we came to a complete standstill. So we decided to diversify our platform, and we've been buying and we've procured a number of equipment much earlier on. The lead time for these equipment is very, very long because of the lockdowns in other countries. So we did procure it some time, but we're now in the process that during June, there's a lot that we've installed, and we'll be installing more. So we've bought a whole lot of additional equipment in order to diversify the platforms. So we also make sure that one lab isn't just dependent on one type of machine, because that's where the problem comes in. So we're giving them a whole range of different machines, dependent on the size of the laboratory. Okay, so I've spoken about we've increased the number of extraction equipment, we diversified the platform. What has really helped us is that our experts have started working on alternative methods of extraction. So we're using which the experts have been working on for the last few weeks, and it's now working quite well, and that has also helped us with the numbers that we're putting on. So things like heat activation and lysis, and we're also using pooling as well. And this has helped us with to increase the throughputs. We also bought extra PCR equipment. The minister himself has been involved in really talking to a number of the suppliers in order to improve our supply. So the issue isn't, we've stabilized the finances of the organization. We've ordered the equipment. We've ordered the kits. It's just that the suppliers just don't have enough kits in the world. We're also looking at more targeted and focused testing. And we're also then looking at the use of rapid diagnostic tests. There's two types. One is with the blood sample, where we take the blood sample, we put it into the machine, and it checks for antibodies. And there's three that we're validating at the moment. There's one rapid test that meets the criteria for sensitivity and specificity, and we're validating that as well. We've asked the supplier to get us the kits so that we can validate it. We're also working closely with the private sector as well as the academic sector, but their capacity is also very limited. The problems that we're facing in the NHLS are exactly the same problems that the private sector is also facing. Chair, just to say that we've had support from a number of organizations, and the president, as the president of the AU, has also announced that they're looking at getting extra kits. The Department of Agriculture and Land Reform has also given us RNA extraction platforms. We've had help from the WHO, the CDC, a number of foundations, and as well as the Solidarity Fund, including Orlando Pirates and the Kaiser Chief and a number of different organizations that has been assisting us. I'm not going to go through the details, Chair. You can, the committee has got the report, but for each of the different provinces, we've worked on a strategy in order to be able to meet to sort out the backlog as well as to meet the surge requirements. So I'm not going to go through those details, Chair. Sorry. Just go back. In conclusion, Chair, so we've upscaled our capacity in order to not to, and we've done it also just to make sure that we don't rely just on those high throughput machines, because we've been very disappointed with the numbers that we've been getting from there. So we're trying to improve our capacity in order to meet that demand. And you can see that we have been increasing it. And I thought it'll just be useful. We've just given you slides just to show the number. This is just for the month of May. So we've grouped together the provinces of Western Cape and Eastern Cape as our priority ones, because you can see that the positivity rates is quite high in these provinces. So the bar indicates the number of negatives, the blue little thing shows the number of positive cases, and then that's the red bar indicates the positivity rate. Gauteng and so just go back. Gauteng and KZN is whilst there's a number of tests that gets done and a number of positive cases, the positivity rate remains fairly stable between 1% to 2%. With regard to the other provinces, Free State, Northwest, and the other provinces, you will see that there's a number of days where there's tests that get done and there's 0 positive cases. And positivity rates, they are below 1%. So that also includes in Mpumalanga and Limpopo. There's a number of days where there's 0 positive cases. So we are keeping a very close watch on all of these cases. Northern Cape, we've been monitoring it because of the increase in numbers in these latter days. And as I indicated, we want to capacitate the provinces there. So Chair, do I stop sharing?
Thank you, Dr. Chetty.
Yeah, we just want the sharing, yeah.
Get your pen and paper to take comments and questions from honorable members. Thanks for your presentation. We are going to request that honorable members, you give each other a space also to ask. The order of asking questions is going to be as I have received it in this way.
Sorry, Chair. sorry, Chair, can I just, the chair of the board for NHLS was going to join us. I'm not sure if whether he's managed to connect. It's Professor Eric Book.
Yes, I am here. I've been here from the start.
Okay.
Thanks, Chair.
Welcome, Professor Book. We'll ask questions because you're a professor. You're going to answer the difficult questions. Let them start. Order of asking questions in this way: Honorable Janji, Honorable Imam Sheikh, number 2, number 3, Honorable Van Staden, number 4, Honorable Gela, number 5, Honorable Kenny Jacobs, number 6, Honorable Wilson, number 7, Honorable Kwahube, number 8, Honorable Ismail, number 9, Honorable Sokacha, number 10, Honorable Chirwa. I have received also another one saying Honorable Malika would like to ask. But when you ask questions, honorable members, please be mindful that you still have to give other colleagues a slot. I now see other members coming in from NCOP who logged in late. Honorable Malika would like to ask Honorable Baha and Honorable Christians. But if time allows, because I will have to stop Dr. Chetty at 4 o'clock, whether she has completed the answers, then the rest you will have to follow them behind. Mamuhlengwa, there has been a procedure how to raise your hand. I've asked you to follow that procedure. Use your gadget where I've asked you to indicate your desire to put. I now see you raising the hand there. Then Mamuhlengwa will be number 11. Thank you. Start, Honorable Janji, and you'll follow one another. You know your numbers now.
Thank you very much, Honorable Chair. Let me appreciate the presentation from Dr. Chetty. I guess, Chair, more than a question, it will be a comment. We appreciate that NHLS is doing so much to work on the backlog. But my plea would be that these 2 provinces that she says they've prioritized, can they really look into it, because those provinces are having a surge before others are having a surge. So that would be the plea, and that we would like to see more of the recruitment of staff so that you do not give the machines to the laboratories and there's no staff to do the test. Thank you very much, Chair.
Thank you very much, Chair. I think I'm next on the list. Chair, first of all, allow me on behalf of the National Freedom Party to extend our condolences to the family of the late Honorable Dora Dunana Dlamini, our colleague that succumbed last night, who passed away. May her soul rest in peace. Thank you very much for the presentation that you have made. Now, one of the challenges that I have, and particularly the National Health Laboratory Services, and that is at the Tygerberg facility that you've got. And I know that you're inundated and you're under tremendous pressure. We accept and understand that. One of the problems I have, and I have written to the laboratory there, I've got a first response and thereafter nothing. And this is my problem. Tests are done right up to the 8th of April. 8th of April. Results are not forthcoming. Then people are going back there to the laboratory. They are given letters to go back to work. And if they pick up any symptoms and things, then they must come back. Now, my question is that would the period of time between when the tests are conducted and the results that are being released, and particularly after the 14-day period, people are going back to work, particularly in the major retail sectors. My concern is the risk attached to this in the delay that is caused by the National Laboratory Services in being able to give the results timely. I'd like you to comment on that. Thank you very much.
Honorable Van Staden.
Thank you, Honorable Chairperson. I have just 2 questions. One is on slide 4. You have a number of 1,171 inconclusive tests. So this means that there is this number of tests that cannot be clarified if a test is positive or negative. I just wanted to know, just clarify with me, what is the reason for this and what is the cost to conduct one such a test in your laboratory? And then my second question on slide 14 is the unprocessed specimens, the figure you showed now for 63,000. Is it correct to say that if a specimen is older than 3 days, that is actually useless and that you can actually get rid of it? Please correct me if I'm wrong in this matter. Thank you, Honourable Chairperson.
Okay, Honourable Kela.
Thank you very much, Chair. Let me also pass my condolences to the family of Honourable MP Dora Dlamini. May her soul rest in peace. Chairperson, my question is on the distribution of PCR equipment to provinces. I know that the presenter indicated that they've excluded Northern Cape. I just want to check, because we've got 9 provinces. I want to check with her why they've excluded the Northern Cape province for receiving this machine. It's because of maybe there's no need or what? If we can get a thorough explanation why Northern Cape was not included. The other question, Chair, I agree with the strategy to prioritize who gets tested. I just want to know, how does this relate to the strategy of NHLS to upscale the number of tests, since the need will be greater as we go forward? That will be my question, my second question, Chair. Thank you.
Honourable Jacobs.
Thank you, Chairperson. Thank you very much for the presentation, CEO. And let me also express my condolences to the family of the honourable member who passed away last night. My question is two questions. One is related to slide 4, which speaks to the number of tests done in the Western Cape, and I'm going to compare that with Gauteng. And I'm a bit concerned if I look at the number of tests in the Western Cape of 114,381 as on the 8th of June, as compared with Gauteng at 151,954, yet the positivity rates are so dissimilar. It does really not speak to each other. So there's a question that needs to be asked here. Has this to do with strategy? What is the real answer behind all of this? And how do we correct this type of testing in line with the fact that we do not have the adequate number of testing reagents and testing kits, etc. So somewhere we need to improve on the situation. We also appreciate the suggestion of reprioritization of testing. And I agree with the strategy. I just want to ask, in line with my first point, is would that reprioritization be uniform for all provinces? And my second point also related to the backlog on unprocessed specimens, and Honourable Gela just spoke to it now. But Honourable Van Staden, the real question here is there any value in still doing tests which have been in the fridges for the past 2 weeks? And how do we align that decision with what it is that we want to achieve? I think primarily we want to achieve the identification of the persons having been COVID positive, number 1, and number 2, who have active disease, and number 3, so that we can get a clinical diagnosis and get our treatment and intervention options prioritized. And not really epidemiological value would be important, but I think in the situation that we are in, and with the surge that is happening, I would like you to maybe address those questions. Thank you very much.
Honourable Wilson.
Thank you, Chair. And again, from our side, condolences to our colleague who passed away so suddenly last night. Our prayers are with her family, her friends and her colleagues. Thank you, Dr. Chetty. I just have a couple of things, and I'm going to reiterate what the Honourable Jacobson from Staden said with regards to the backlogs, and I hear both of their concerns. I also have a concern with regards to backlogs, because as long as there are these big backlogs and specimens are lying around, we run a huge risk too of contamination of those specimens, and that is a bit concerning for me. And during this whole lockdown process and dealing with throughout the whole lockdown process and the dealing with the pandemic, this has been, it's fallen under the Disaster Management Act. Can you, Doctor, advise which regulations under the Act govern the tests for COVID, if there are any? And can you please explain to us why we get discrepancies in figures from provinces? And I'm just going to highlight one case. It's one of a few that we've got, where we got, for instance, in Limpopo, an area called Maraleng, one day had one case. The following day, when the figures came out, that case had gone. It was back to 0. 2 days later, the day after that, it was suddenly 2 again. It's very disconcerting, because people are following these cases, you know, and the progress of the pandemic and infections very carefully. And they get quite alarmed because they're not getting correct figures and they don't know how it affects them. Fear, obviously, being the ruling factor. And Dr. Chetty, you don't have to answer this today. I don't mind getting it in a question, because I'm not sure if, in a written question, I'm not sure if you are in a position to answer it. But in light of the tobacco case that is in court today, do we have any statistics on how many of our COVID deaths were actually smokers? Thank you, Chair.
Honorable Kwahube.
Thank you very much, Chair, and thank you to Dr. Chetty and her team. Just a few questions on my side. We understand right at the beginning of the pandemic, one of the things that we had said was that the testing capacity needs to be ramped up significantly. And in fact, the department had set a target of testing between 15 and 30,000 tests per day. So I understand that that has not happened. And obviously the backlogs, and I mean, I've seen that, you know, we've hit some around the 20,000 marks, but also the backlogs have now undermined our ability to effectively fight this pandemic when people aren't able to get their results back in time. Now, what I want to understand is what kind of strategies have we employed, particularly, Dr. Chetty, where it comes to developing local and domestic capacity? Because what I understand is that some of these reagents and some of these equipment that we are lacking from the global community are things that we cannot necessarily replace. But then, you know, we've now had 3 months. What kind of local capacity are we building to be able to bring those online? And then lastly, then the question around the gene expert machines. Although I know that they require cartridges, which are also one of the things that we are lacking, what is the criteria used to distribute these machines across the country? So how many are allocated per province, and what's the criteria that is being used there? Thank you.
Honorable Ismail.
Thank you, Chair, and once again, thank you for the presentation. My main concern is the backlogs of results. Basically, it's a nightmare. You know, I've been doing a lot of oversight, and I have health professionals telling me that it's really making no sense. We're testing hundreds and receive no results on time. People have been tested and they've been waiting for results. They went into isolation. They've even come out of isolation, and they've gone back into their, you know, places of work, and still the fact that we don't have results is just putting more people at risk, of getting the virus. Secondly, is that how much does a test cost? I mean, is there any national guidelines on pricing? Because there's a vast difference between the labs charging for this COVID-19 testing. And we've also had issues where patients have gone to be tested and then they've been told that if they are tested positive, the medical aid will pay. And if they tested negative, they have to carry the burden of paying for the price of the testing themselves. So that is something we need, guidance on. Thirdly, is that I see my colleague have asked that, but I just wanted to know how many patients on ventilators presently are actually smokers. Thank you.
Honorable Sokacha.
Very much, Chairperson. Chair, let me also welcome the presentation made by Dr. Chetty. Chair, I've just noted some few inconsistencies on the information given to us about provinces. The first one, Chair, is around the capacity at the NHLS, the virology laboratories. Honorable Kelly asked that question, where the Northern Cape is not presented there. The second one, Chair, is also around the unprocessed specimens. I've seen there are about 4 provinces that are not included there. And then the other one is around the provincial action plans, where Western Cape, Eastern Cape, Gauteng, and KwaZulu-Natal are the only provinces that are noted there. That is my first question. Why the inconsistencies when we get information about provinces? Then the second question, Chair, is around the test kits. What is the situation? Do we have shortages of test kits, or are we up to date in as far as our test kits are concerned? Thank you very much. Honorable Chirwa.
Thank you, Chairperson. Condolences to the family of MP Honorable Udlamini. May God be with them during this hard time. My questions are as follows. I want to hear from the NHLS, what is the rationale between or behind procuring laboratory material in Western countries and not procuring them locally, and what the ratio is, what the percentage is of local procured equipment by the NHLS domestically in South Africa as compared to internationally or in other Western countries. I also want to ask, how big is the capacity of the NHLS to monitor laboratory tests done in the country if they are legitimate? Because a lot of concerns and grievances have been brought out to say people have passed on due to different illnesses, but their death certificates are stating COVID-19. What is the legitimacy of the tests that are conducted and the data that is shared by the department through the NHLS? And also, why does the prioritization of testing being done to people who are already in a hospital when those who are outside actually have a higher chance of spreading COVID-19 than those who are already hospitalized? I think the NHLS must relook at this reprioritization, and people who have COVID-19 symptoms who are already in hospitals should be treated as COVID-19 patients from the get-go. And those who are not ill enough, or rather who have succumbed to the illness or the symptoms, and who are still outside, should be prioritized because they are more at risk of spreading the virus than those who are in hospitals. And also, we got complaints about the NHLS calling people and asking for 1,800 rand for tests that are conducted in public hospitals. The latest one was from Somerset Hospital. Yeah. Are these tests not free? And if they are, why do you have a call center established? And lastly, can the NHLS also just tell us why they don't have region-based strategies in conducting tests and responding to COVID-19? Because this umbrella approach is not going to work. And we've raised this time and again that you need to have region-based strategies, because these regions that you keep giving them umbrella practices and strategies don't function the same way culturally, socially, economically. The NHLS must break down its priorities and put them in region-based operational center. We've been saying this. I don't know why it's not yet been done. And I don't want to cite laziness, but there must be more done. I mean, we can't accept that NHLS only has a strategy nationally or provincially when it's not enough, and it's clearly not enough. Okay. Thank you, Chair.
Yeah. Honorable Mama Shengwa. Ma'am Shengwa, we cannot hear you.
Thank you, Chair. First of all, let me pass our condolences as an IFP to the Dlamini family and the ANC party. Such a loss. That is a sad news and shocking. May her soul rest in peace. And then let me welcome the presentation. Partly my question was, Mama Chanti was asking what I'm going to ask about the recruitment of the staff in the laboratory. But now, my worry is that, is there any policy put in place in order to reduce this backlog of testing? Because this testing is down in our provinces. We have done the oversight where we see that there is nothing happening in the laboratory because of the lack of staff, shortage of staff. I thank you.
Honorable Malika.
Thank you, Chairperson. Let me pass condolences to the Dlamini family. May his soul rest in peace. Chairperson, I want to check that does the NHLS have the capacity to monitor whether all the laboratory tests done in the country that are legitimate? And how much has NHLS spent on private laboratories due to shortage of consumables? My last question is, there have been complaints on lack of response of inquiries sent to NHLS or NICD. What is the reason for this and what is being done to correct it? Thank you, Chairperson.
Honorable Christians, Bacha first, yeah. Bacha and Christians last.
Chairperson, let me also welcome the report as presented by Dr. Chetty. Just two questions from my side. One, there's been a report that some specimens probably are ferried by road from the Eastern Cape to Gauteng, and I just want to check whether such is a fact, and if it is, doesn't it have a bearing on the inconclusivity of tests or specimens that are received? Two, the second one, Chairperson, is on the backlog itself. To what extent does this backlog contribute to further or continuous infections, wherein people are waiting for results and they still have to then go back to communities and probably spread the virus unknowingly because they might not have received their results back? Thank you, Chairperson.
Honorable Christians, you are the last one.
Thank you very much, Chairperson. My question is just around the procured 67 mobile vans that were deployed to provinces. I think it was early in April. Now, in light of this shortage of the kits currently, what is the responsibility then of these vans that have been deployed to provinces? Are they still adequately capacitated to do their job in provinces? Are they still working? And then also, in which provinces are these vans deployed, these mobile testing kit vans? And how can community members access these vans for testing? And then just the second question, which has been touched by other members, but I'm particularly concerned as I am from the Northern Cape province, is the Northern Cape stats. Now, currently we are on 134 positive COVID-19 patients there, but that doesn't seem correct at the moment. We would like the true picture of the Northern Cape. Just today in the media, the SABS building has been closed, the SABC building has been closed in Kimberley, where a high-ranking official has apparently been tested positive. Why has the Northern Cape been excluded, and when will we get the proper information with regards to the Northern Cape? Thank you, Chairperson.
Okay. Dr. Chetty, you will have about 14 minutes to reply. Honorable members, I'm reminded that when you speak, like most of you have done, please switch on your video so that you can see who is speaking and sitting where. You have done that excellently. Continue in that way. On all the things that you have said, I think maybe it would be nice, it would be important that we close the meeting with the statement that we set as a portfolio committee, and we received the bad news about the passing on of Honorable Dora Dlamini, and we express our condolence on behalf of this committee to the family. Thanks. Dr. Chetty, I will stop you at a minute to wrap up, to remind you at a minute to 4. We have a net care group coming in to make presentations to us now. Thank you. You can now start.
Thank you, Chair. I'm not sure whether Prof. Book wants to come in at this stage.
No, I'm happy to make one or two comments right at the end, if there's time after you've replied.
Okay, thank you, Chair. So with regard to the first issue that some of the provinces need to be further prioritized, that's exactly what the NHLS is doing, you know, we with the provincial action plans, you can see that we're buying more equipment, we're selling more test kits into those provinces. And the issue around staff getting recruited, we've made this a #1 priority. So we've made it very clear to all of our provinces that any staff that's required must be recruited, and this has been happening. And it's not just it's not just the staff in the laboratories. I think it needs to be pointed out that the toll-free, the call centers that we've established was done extremely rapidly within a few days. We recruited masses of nurses to work because it's a 24-hour hotline. And at one stage, we were getting over 100,000 calls. So the nurses work in shifts throughout the day. We made sure that there was enough. We recruited doctors into the doctors hotline. We've now got a results hotline that we also have recruited individuals. Over and above that, all of the mobile labs, the mobile vehicles that we bought, we've staffed them with 2 nurses and 1 driver in each of those vehicles at the NHLS cost. So this has been a value add that we've brought in, and we've made sure that all of that gets done. Chair, the second question from member, the MP Imam. I'm trying to work out the issue around Tygerberg, and perhaps I'm not getting what the issue is there, because in Tygerberg Hospital, the backlog has been cleared. Sorry, I don't have COVID. It's my throat is just. I just need to drink some water. Okay, so the issue there has been as to the risk in giving the results because of the backlog, giving the results that's not timeous. Chair, just to say that every person who gets tested should have been tested according to the case definition of being symptomatic or being in contact with somebody who was positive. And every single person who gets tested gets counseled that they need to go into quarantine, right, or isolation, self-isolation, until the 14 days has expired, and that should have been practiced. So that should not be impacting on the individuals spreading the disease during that time. If after that 14 days they would have been counseled, if they don't have symptoms, if they're not sick, then they would be able to go back to work. So the backlog itself should not be affecting what people's behaviors are, because they would have been counseled to make sure that they do practice those safe behaviors. I'm not sure what letter has been given by Tygerberg, so maybe I won't comment on that. The issue from MP van Staden on the inconclusive reports, the issue is the inconclusive reports is normally where the machine itself, which is in some instances the machine has got the software that will say this result, we cannot get a result because they either didn't identify one particular gene and they couldn't come out to say whether it's clearly negative or positive. The labs would contact the individuals or the clinician to say that the test must be repeated. The number that we've got that's inconclusive is not that high, because normally this would happen with a lot of machines. It's where you have difficulty in being able to come out with a clear result from a specimen. And it could also be because of the whether the specimen was adequate, whether they actually got enough of the sputum when they took the swab. And so there's a lot of reasons around that. The cost, a number of people have asked around the cost of conducting one test, and we've estimated the costs differ fundamentally dependent on what reagent gets used, but we've worked on an average cost of 507 rands per person. The issue around if a specimen is older as to what's what's the quality of that specimen, and I need to state that whilst we know that biological samples over time may deteriorate, we also aware that what our results are showing doesn't support that theory. So what we are doing is we're currently conducting an experiment to investigate how long the RNA can be detectable in these samples, and in order to get the evidence, because you can't say there's different papers that have been written that where it's been stated that if you store it in a particular environment at a certain temperature, then it can last for a number of days. So we're conducting tests now in order to look from an evidence base as to how long the samples will last. We don't want to, I know that there's been a lot of theories that are going around that saying it could be 2 days, it could be 5 days. As the NHLS, we believe that the evidence is important, and once we've done that, we'll be able to come back to you. The issue around the Northern Cape and whether it's been excluded, I just need to clarify this. Northern Cape has not been excluded, but just to say that the current platforms that we are using, so most of the platforms, the COBAS, the CGene platforms, all of that, except for the Gene Expert, but all the other platforms, the test has to be signed off by a virologist. So the virologist looks at the different patterns because they are testing for different genes. And they need to sign off to say that that's a positive test. And therefore, the test can't be done in any laboratory. it can only be done in laboratories where there's virologists. Now, we don't have virologists in every laboratory, so it can't be decentralized. And in the Northern Cape, we don't have a virologist, but that's why we're looking at a plan of getting a virologist to support the Northern Cape so that we can get equipment there. The Northern Cape does get test kits from the gene expert, so that does get included, and I should have put that into the presentation. So the Northern Cape does do some of its own testing, but we're looking over and beyond that of getting some of the other equipment into the Northern Cape. The issue around the priorities for the testing going forward, that's in discussion with the National Department of Health. And once that discussion has been finalized, it will be circulated. The questions from Member Jacobs, the issue around the differences in the numbers between Western Cape and Gauteng, until recently, most of the provinces were testing according to the same case definition. And proportionally, if you look at the number in the populations, the Western Cape is doing a lot more tests, understandably because of the number of positive cases, than some of the other provinces. So you do also need to look at population size in order to look at the numbers.
Dr. Chetty, please can you improve your speed?
Okay, thanks. So the reprioritization, I've said, will be discussed with the National Department, and each of it is a national policy. The issue around risks of contamination with the backlogs, we make sure that there is no risk because it's stored under very careful conditions at a particular temperature. There aren't any specific regulations that relate to the testing. The question from Member Wilson. I'm not sure, Member Wilson, as to what are the changing numbers. The stats that get given out are the stats from NICD, which includes also the private sector. The stats that I'm giving you is just for the NHLS. The issue around stats on smokers has been asked a couple of times. We do not keep those stats as the NHLS. We only keep stats on the tests that get done, not on the clinical history. That comes from the Department of Health. The issue around the testing capacity as of 15,000 and then 30,000, I've indicated that that's the throughput of the machines. But right now, on average, in the last week, we've been doing more than 15,000 tests per day, and we're building up the capacity with regard to the 30,000. But as I've said, it's dependent on the ability to get those test kits. We are trying every means to get those high throughput test kits from our suppliers. The issue around the suppliers is that we can only use the test kits from those suppliers. We do have local manufacturing where there are some companies now that are looking at manufacturing some of the kits. We've got the ability to make those kits ourselves, and we have been doing that, but it's quite time consuming. So that's why it's easier for us to use the ready-made kits. But the Department of Science and Innovation is assisting the SMMEs with regard to the others. The gene expert we've got over 325 machines in 171 sites throughout the country, so it's very well distributed, allocated in all of the provinces. We're also getting more of those machines. The issue, I've spoken about Northern Cape. The provinces that we concentrated on are the provinces that have got the high positivity rate, but there are action plans from all the different provinces. The issue around monitoring of data, we've got a very good monitoring system. We've got one of the best central data warehouses, and the data that we've got is consistent. Everybody utilizes it, so it's very good data with regard to that. I'm not sure, please, Member of Parliament, the issue around our call center asking people to pay for tests, I mean, that's not on. And if you've got any information with regard to that, we don't charge for the tests. So please let us know, because I'd like to know if there's somebody who's abusing whatever situation they're in, and we will follow that up. And then just around the recruitment of staff, we've recruited a lot of staff, and I've spoken around that. The testing in the provinces are not down; they've been increasing. And the issue I've spoken about, whether the backlogs are going to affect the tests and further infections, and that should not be the case. The important thing is that we've always said that clinicians need to be able to manage their patients regardless of whether there are results there or not, and we will continue to stress that. The issue around the 67 mobiles are distributed throughout the country in every province. We've provided the stats as to where they're distributed, and it's not all of the mobiles have been equipped with the machines, because the other half of the mobiles is used for sampling and screening, and it's been very, very effective because you need to have a private place, and we'll try and get the information. It's the Department of Health who decides where the mobiles go. But they've been very effective. Okay, so thank you. I think I've fairly covered it.
Yeah. Can we give Professor Book a slot for 2 minutes? So long, Dr. Chetty. I'll be giving your details to the portfolio committee members. They want to make a follow-up. I'll give them your number. Okay. Professor Book. Professor Buch, we cannot hear you.
My apologies. Just to say that the board of the NHLS has been following this since the beginning of the year. We've been tracking how we've scaled up and how we've managed the situation, and the board is very pleased with the way the executive team have responded. The big challenge for us, as you know, is to be able to get the test kits. And we started ordering them very early in the epidemic, early in the year, and we have been expecting many more kits than the suppliers have been able to provide. So it was not a slow start on our part to order the machines, to order the test kits. And we continue with the support of the Minister of Health to try and expedite getting in the number of tests the country needs. But the challenges are complex and global, and so we continue to work in that regard. I think that from our part, I just want to clarify when Dr. Chetty says we don't charge for the kits. As you know, the way the NHLS works for the test, the way the NHLS works is that the provinces order the tests. We bill the provinces according to a price schedule approved by the Minister of Health, and that's how it's funded. So individual patients, unless they are private patients, would not get billed by us. We would bill their hospital or their clinic for the tests that have been done. At this point, we have not billed anyone for any of the COVID tests. We have not billed the provinces at all, but we cannot continue to fund this from within the NHLS. Because we've improved our financial situation and we've reported to the Portfolio Committee on our progress over the last 3.5 years, we were in a financial position to make the investments required by the country to scale up our equipment, our test kits, our personal protective equipment, and all the other requirements from the resources that we had within the NHLS. But within the volumes of tests we are doing, we are going to need to charge and recoup some of the money that we have laid out. And then just finally to indicate that the board has extended its appreciation to the executive team and to the staff for the exceptional effort that has been made by the NHLS executive and staff throughout this COVID epidemic. Staff are working extremely long hours. I usually talk to Dr. Chetty by about 7 o'clock in the morning on her way to the NHLS, and I often talk to her late at night, well after dinner time on her way home. So I think, I just wanted to appreciate that effort. Thank you.
Thank you very much, Professor Buch, for actually leading from the front, accompanying the CEO, Dr. Kemi Chetty, who has given us a good presentation. We are grateful about this because as portfolio committee members, we get concerns over issues that are coming up. I think the members, I have given them your number, Dr. Chetty, in case they would want to make a follow-up on some of the issues that we have raised. But once more, thank you very much for your presentation. And you may stay if you so wish, but we are now switching over to another presentation. Thank you very much. You can then leave well if you do. Let me check if the leadership from Life Group of Hospitals
Thank you very much.
Thank you.
Honorable Chairperson, it's Ansia Pediachi from the Life Healthcare Group, and the Life Healthcare team is linked in.
Right. Mrs. Padayachi, thank you very much for coming through. I have indicated that we would like to appreciate you for bringing the presentation to us early on time. We have been able to go through it, so we will only afford you 15 minutes to take you through the highlights, not the whole point by point, so that you can allow members to ask already the presentation that they have read. Honorable members, please start sending your desires, including Umamhlengwa, on my cell phone. Write down if you want to speak, then I can note you so that after the 15-minute summary by Mrs. Padayachi and her team, you could then start.
Okay. Thank you, Chairperson, and good afternoon to honorable members as well. My name is Ansia Pediachi, and I'm the Manager of Community and External Affairs for the Life Healthcare Group. We'd like to thank you for the opportunity to address you today. Representing Life Healthcare in this meeting today is Adam Pyle, the CEO of Life Healthcare SA, Matthew Pryor, the Executive, Funder Relations and Strategy and Development, Dr. Trevor Frankish, who's a Life Healthcare COVID-19 Clinical Representative, Andre Joseph, the General Manager, Funder Relations. Honorable members, in the interest of time, and as the Chairperson has just indicated, our presentation has been condensed to allow for more time for discussion. Through you, Honorable Chair, I now hand over to Adam Pyle to start off our presentation. Thank you, Adam.
Thank you, Ansia. To the Honourable Chair and members of the Honourable members of the Parliamentary Health Portfolio Committee, thank you very much for the time this afternoon, and thank you for affording us the opportunity to interact with you. Andre, do you have the presentation up? Was it?
Adam, can you see it?
I can't see it. Can anybody else see it? While Andre gets it up, there's a few introductory, just a few points. We only have 15 minutes, so Andre, what I'd like to do is, there were a few slides up front covering who Life Healthcare is. I think what we should really do is bypass those slides. It was really covering our facilities in Southern Africa, our operations in Europe, and also what type of facilities we have here in Southern Africa. I think what we should rather do is move forward into how we are tracking and dealing with the COVID-19 pandemic. I think that'd be far more use, and we can cover that in 15 minutes, then take questions after that. So I think, Andre, it'd be much better use of our time if we just bypass the first few slides and then move on to Matthew's slides, which sort of cover the Matthew, then Trevor, then yourself, in terms of how we're handling the pandemic.
Adam, I'm unable to get that presentation up. I'm sorry. Trevor, can I ask you to maybe try?
The presentation was already up when Mr. Padayachi spoke. We saw it when Mrs. Padayachi was speaking through. So what has happened to it now?
Oh, there we go. It's back up.
Is it visible now?
Yes, it is back up, Trevor. So, Trevor, do you want to just jump to slide 5? I think that's the keep going down, keep going down, keep going, and we'll hand over to Matthew at this point here. Thank you very much.
Thanks, Honourable Chair and Honourable Members. I think our response to this pandemic really revolves around 3 particular pillars. First of all, looking after the community in terms of patients and visitors. Our employees and our hospitals are an important pillar along where we are trying to ensure that we have adequate response. And then, of course, enormously is our engagement with government to ensure that we collaborate on the management of the pandemic, report data to be able to guide the national response, and of course also to make bed availability available to treat state patients where such capacity is available. Can you put on the next slide, please? So I think our response has effectively and collectively to engage with various parties in order to ensure that the industry responds as effectively. We are engaging through both the Hospital Association of South Africa as well as Business for South Africa through the new B4SA. We, of course, are also engaging with all spheres of government. We have given presentations to the KZN, the Eastern Cape and the Gauteng Health Portfolio Committees. We are engaged in the provincial COVID task teams at the Gauteng and Western Cape, and of course engaging with national. We obviously want to assure that the safety of our staff and preserve their jobs, except of course that we are going to get things wrong sometimes, to reflect and share learnings and best operating practice, and of course, have some agility in our ability to respond to the pandemic. I think I just wanted to give you a feel of some of the emerging challenges that are coming from the pandemic. I think healthcare availability is certainly becoming a major concern. There's an isolation and quarantining policy, which is essential, but nonetheless that does reduce the capacity of staff available for ourselves. There's normal sick leave, of course, for people who might actually have contract the disease. We have to shield vulnerable staff, particularly those with comorbidities or are aged. And then, of course, we also are facing some reduction in staff due to them accepting 12-month state appointments. This is causing particularly shortages in the Eastern Cape and the Western Cape at the moment. Procurement of PPE continues to be a challenge. Recent removal of the ITAC credit is problematic. We are trying to support local manufacturing wherever possible, but some of the PPE does have to be imported, and we are making a plea through to the applicable ministry to ensure that that ITAC rebate on the duties does get reinstated. Community transmission is definitely a challenge. We obviously need to ensure compliance with guidelines and protocols. Given the number of guidelines and protocols that are out there, this is proving to be extremely difficult, as well as given the lack of detail in some of those guidelines. We need to retain some ability to cater for non-COVID patients. This is also proving to be a challenge. Ongoing emergency and necessary care does need to continue alongside the COVID treatment. Labour union involvement continues to be a challenge. It does require that we often have to engage and provide information, and we have had some challenges with some of the unions at some of our facilities. We need to ensure that there's an adequate supply of oxygen, and we are involved in a task force to ensure that the oxygen supply is adequate. We think that there is a bit of a shortage and availability challenges around high-flow oxygen supply, and then some inaccurate media reports certainly not helping the situation. If I can go on to the next slide, which really talks to the bed capacity negotiation that we've been engaging with at the national level. We obviously are wanting to help support the pandemic, and we think that really we've got to the point now with national where we have an agreement. The contracting will happen separately between ourselves and the doctors and other professionals, and there will be a role for an administrator to play to ensure that claims are paid on time and accurately to the various providers. The referral will happen on a doctor-to-doctor basis. We're calling it a JOC that will exist in the public system, a JOC that will exist in the private system, and that the referral will really involve the handover of a patient at the individual level. And the basis of the tariff that has been proposed, although we haven't had official confirmation from the NDOH down to the provinces yet, is based really primarily for critical care beds with a split of 55% high care beds and 45% ICU beds. There's also a care beds and a rate for palliative care. The critical care rate that has been proposed is 16,156 Rand. This includes VAT. It includes obviously the nurse, the bed, and all the stock that is used. Now, we have shared some data with the Department of Health around the utilization of stock. This is a pure cost to life healthcare. We don't make any margin whatsoever on the utilization of stock in our hospitals, and we are absolutely, we remain, concerned that this is not really on a cost recovery basis. It is below that, and we would face sustainability challenges for our organisation should this rate persist for any extended period of time. With that, I think I'd like to hand over to Trevor, who will speak a little bit about healthcare worker and safety. Thank you, Honourable Chair.
Thank you very much, Honourable Chair and Honourable Members. So just to emphasise that the mental and physical health of our staff is vital. I just want to check, is the video working properly? Okay. Well, very often the issue about PPE is in the headlines. We do provide that within the NICD guidelines and various other professional societies and international guidance. But it's very important that PPE is only one part of infection prevention. The others include the hand washing, the social distancing, etc. We do make sure that our employees are trained in the use of PPE, including how to put it on and take it off properly. We're very aware that very often when infection is transmitted, when they're taking PPE off after dealing with patients. So we manage the persons under investigations and COVID positive patients according to the guidelines. Clearly, disinfection of surfaces and environment is important and is ongoing, and special measures are taken. With our vulnerable employees, we are trying to avoid them being in the front line and therefore exposing themselves, and we rotate our shifts to minimize the emotional and physical burden. And also to protect staff, we've offered influenza vaccinations to employees and the doctors. Just trying to move it on. I may have to unshare and then share again. Okay, if our staff do become exposed to COVID positive persons, we assess them individually. How high is the risk? The NICD has provided very valuable guidelines on how to manage it. I won't go into the details. That's available on the site. In terms of quarantine and isolation facilities, we do have facilities within our hospitals or in other facilities such as bed and breakfasts or hotels where we've obtained accommodation for them. Our employees and their families also have access to our in-house employee wellness program, which is delivered by Life Employee Health Solutions. And we are very aware of the trauma the psychological trauma and anxiety that staff are going through, both when they've been diagnosed as positive and also when they are in isolation. And we have an assistance fund to our employees. We have a particular program with the Gauteng provincial government, which I won't go into detail now, but this is just some of the information that we share with employees in Gauteng. In terms of our healthcare workers exposure, we have something like 16,500 employees. We report any exposure or COVID positive cases to the various departments of health. And today, just under 2% of our staff have actually been, staff and doctors, because they are not employed by us, have been diagnosed as positive. So there's the breakdown by province there, but also in the interest of time, I won't go into that. That's in the presentation. You will see certainly in the Eastern Cape, Western Cape, the high numbers there. Just in terms of Life Esidimeni, we have a number of facilities, particularly frail care and chronic mental health facilities, just shown there. Again, if we look at the situation in the Eastern Cape, we are talking mentally challenged people and frail people, where it is very difficult for them to comply with the norms required of social distancing, hand washing, and so on. So it is a particular challenge in those type of facilities. And then I'll hand over to Andre Joseph to continue with the risk reduction.
Yeah, thank you, Trevor. Can we go to the next slide, please? Yeah, thanks, honourable members, for the opportunity. Reducing the risk in our facilities is obviously important. We want to keep the virus outside. To do this, all visitors and the patients are screened on arrival at our facilities. And if some of them are found to be symptomatic, they are directed to a designated area, usually in our A&E department, to be properly assessed. And if necessary, then they are treated as persons under investigations. Our employees and our service providers are monitored on a daily basis for early symptoms. So as they arrive for the shift, they go through a medical surveillance. And if they do have symptoms, they are sent home. We are now trying to get them to do the symptom checking before they come to work and then stay at home. In the same way, doctors working in our hospitals are also monitored for symptoms. Universal masking has been introduced about 4 or 5 weeks ago to reduce transmission from asymptomatic or pre-symptomatic carriers. So you'll see that within the hospitals, all the staff, the visitors, patients are masked. And then, very important, as Trevor also alluded to, health education on standard precautions against infections for employees, visitors, and patients. And Life Healthcare has made cloth mask and hand sanitizer available for all its staff for use to and from home. So the hospital proper is important, but the adjacent facilities are also a focus. So therefore, the consulting rooms, radiology, and the path labs, in these areas, we limit the number of patients waiting, and we advise our doctors to use telephonic consultations as far as possible. As before you enter the hospital, there are temporary facilities that have been erected to screen visitors outside of the hospital. As the winter months approach, it's becoming more and more difficult to keep that outside, and we moved it to just directly inside of the hospital. In the admissions area, you will be aware that if you are admitted early in the morning or midday, there's usually a lot of people in our admissions areas. We got around that by actually staggering the admissions time, and the social distancing is enforced. Wards and high care, we have some actions there to ensure that the virus is not transmitted. And in theatre, theatre is our least risky area because, sterile practices are already in place in that area, but there are still, especially in the staff canteen and change rooms, we do enforce the social distancing. Next slide, please, Trevor. Just going to talk a little bit about disaster planning and surge planning. All our hospitals in Life Healthcare have surge plans in place. These have been verified by independent persons that are separate from the local management. We wanted somebody to go around to do the verification orders to see that things are in place. Then outside of the local hospital, there's a regional plan to assist if any individual hospital should run into trouble. At the moment, the private hospital industry is working on a bed availability application. As the numbers increase, we're going to have to know at a moment's notice where a bed is available in public and in private sector, and we hope that this application will help with that. We do have virtual meetings thrice a week to gauge the situation on the ground, and this is where local managers really share all the best operating practices. We still have to make provision for non-COVID cases that are medically necessary, as Matthew alluded to. Resource capacity. Next slide, please, Trevor. A very important aspect of our response to COVID is the establishment of doctor COVID committees. These have been established at every hospital, and they really assist and guide the hospital with disaster and the surge plans. They do plan for the availability of doctors. As doctors become infected and have to isolate or quarantine, we have to have a supply of doctors coming through. They consider and agree the clinical guidelines using the NICD guidelines as the base, and they advise on clinical management where the NICD guideline is silent. So where the NICD doesn't address a certain matter, we refer these to the doctor COVID committees. They're also charged with the education of other doctors and on the clinical protocols. Not important now, but we do think it will become important later, is a subcommittee that deals with ethical issues around utilizing non-treating clinicians. And this is really will become important where we have to decide who is treated and who is not treated. We've also then engaged with professional associations of specialists for guidance on clinical management. Next slide, please. This slide really just talks to and summarizes.
Hello, I asked you to condense your presentation so that you allow members to ask you questions. Now, these are the questions, these are the slides we would have wanted to have earlier on, and now your time is running out to present.
Okay. So these are the just a summary of per province. We've put adult beds, adult high care, adult ICU. This excludes the neonatal and pediatric and oncology and maternity beds because we still have to preserve those. So we only showed you the adult beds as well as the ventilators and the anesthetic machines. Next slide, Trevor. Reporting is available really so that we can guide our response. And this is just to show what has happened just in life healthcare and how the numbers have increased in line with the epidemic that we've seen in the country as a whole. Currently admitted, you can see Eastern Cape and Western Cape again as in the rest of the industry, both public and private. Eastern Cape and Western Cape has the most patients admitted. Currently, we have 301 patients in our hospitals, of which 154 is in the Eastern Cape and 65 in the Western Cape. Deaths, 63 in the Eastern Cape and 16 in the Western Cape. We have 93 deaths since the 22nd of March when we admitted our first patient. Next slide, please. Life Healthcare reports into the NICD and every day. So we report by 11 o'clock in the morning. NICD reports into the provincial and the national ministers by 2 in the afternoon. And so we'd want to recommend that the NICD reporting route remains that because we think the data gets cleaned and all duplicates are removed and there's one repository of data. Thank you.
Thank you, Andre.
Honorable members, thank you for that presentation. We would like to request that you ask questions in the following order. Take your numbers down. Number 1, Honorable Kenny Jacobs. Number 2, Sokacha. 3, Honorable Chirwa. Number 4, Honorable Janti. Number 5, Honorable Imam Sheikh. Number 6, Honorable Kwahube. 7, Honorable Malika. Number 8, Honorable Baha. Number 9, Honorable Christians. And number 10, Honorable Ismail. I haven't been able to ask questions. Let me start. Last week we were doing oversight in the Eastern Cape, and we actually were shunned by one of your CEOs at Umtata Life Care Hospital. I did receive an apology from Mrs. Padayachi, but she didn't explain. Of course, she was not able to. She couldn't explain why that CEO behaved the way he did. I would like to actually get that, even if it is written to me separately, but that was actually an unbecoming behavior when we were doing an oversight in one of your facilities, and he's actually not available or willing to share with us this information that we now have in front of us. Honorable Jacobs.
All right, so we come out of that briefing by the Portfolio Committee on Health, led by Dr. Sibongiseni Dlomo there. So what we saw earlier at 3 o'clock, the National Health Laboratory Services were giving their report back on the COVID-19 test results, as well as some backlogs. So a number of issues coming out of that presentation by NHLS. Amongst issues that came out, they were also comparing number of tests that were conducted in April. For example, 94,203 tests were carried out, and between the 1st and the 7th of this month, over 100,000 tests were carried out. So they were breaking the numbers according to the different provinces, also indicating that Gauteng province, so the Western Cape as well as the Eastern Cape, have the highest numbers of tests. That we know, of course, is as a result of the highest number of infection as well. Touched a bit on capacity of machinery in the different provinces. Also looked into issues around a number of samples that are given on a daily basis. So as it is now, we have a backlog in tests of about 63,000. But of course, the National Health Laboratory Services, they're vowing, saying that they will continue to improve on that number. But as it is now, they're prioritizing on the Western Cape province, as I said, due to the highest number of infections in that province. So they've also sent through extra test kits to reduce that particular backlog, saying they still have some backlog challenges here in Gauteng as well as the Eastern Cape. But they've also indicated that as it is, they sort of prioritize for in-hospital patients, and their observation is that the backlog is mainly in communities more than anything else. So MP is also asking questions there, seeking clarity on inconclusive tests, amongst others, and also saying that it becomes a bit difficult to fight this pandemic if people do not get their results on time. Others wanted to know about the criteria that's being used to disseminate the machines across the provinces. And as I said, that no results will then put more people at risk of contracting the coronavirus. So that's basically it. So as it is now, what you see now is the second presentation that is being made by the live healthcare groups, talking about their preparedness to fight COVID-19, the response to the pandemic, the challenges that they face. So as we moved out of that discussion now, members of parliament were asking questions to the live healthcare groups. That's basically it. The discussion, or rather the briefing coming out of parliament by the Portfolio Committee, looking into issues around the health system, led by the chairperson, Dr. Sibongiseni Dlomo. Let's take a quick break.